Okay, so the last thing that we're going to talk about today, or in this module, is the acquired cardiac conditions, which we alluded to a little bit in the previous lectures. Here are your learning objectives, so you can go ahead and review those. We're going to talk about rheumatic fever, Kawasaki's disease, and infective cardiac diseases. So rheumatic fever basically is incorrectly treated strep throat or scarlet fever. So if a patient has had a history of strep throat or scarlet fever, then we might suspect rheumatic fever when we talk about more of the symptoms. It is caused by group A streptococcus. It generally occurs 1 to 5 weeks after the initial infection by strep. It's a generalized inflammatory response. It's basically the immune system overreacts to the infection and creates this generalized inflammatory response throughout the entire body. So what we're going to see for signs and symptoms, you're going to have high fevers for days, a couple days. Painful and tender joints, mostly the large joints are going to be painful and tender. They're going to have symptoms of maybe congestive heart failure, very tired, certain jerky movements or chorea. Some of the more rare symptoms include painless nodules near the joints, so they'll have these nodules, but they are not painful, and they will be located close to the joints. And they may have pink rings with a clear center rash, and those are more rare symptoms in rheumatic fever. So complications, why we call this an acquired heart defect, meaning that this is a heart defect that is a result from an infection and not that they were born with. And other complications will include a heart murmur. They could have an enlarged heart, and fluid can build up around that heart as they get sicker if they're not treated. So how are we going to diagnose? Basically, we do a strep test. We see if they've had a recent or if they've had antibodies to strep A. So we're going to test for their antibodies. The strep test can be negative or positive, so that the strep test is not going to be definitive. What we're really going to look for is the antibodies in their blood. We're going to do an EKG or electrocardiogram to see if they are having any arrhythmias. So when the heart gets enlarged, sometimes it affects the conduction system, so that can cause arrhythmias. So we're going to look for those. And then we're going to do an echocardiogram because we're going to look at the structures of the heart. So rheumatic fever can cause valves, issues and problems. And so we're going to look at those structures to make sure that they are normal or abnormal and treat them from there. How we are going to treat them is we're going to give them high-dose aspirin, also NSAIDs to deal with the inflammation because this is an inflammatory response, so we want to manage that inflammation. If they have a current strep infection or they have suspected current strep infection, even with a negative test, they will probably put them on antibiotics to make sure that they get rid of that strep infection. They may put them on anticonvulsants for the chorea. That can include valproic acid or carbamazepine. And then supportive care, so basically making them comfortable, treating their pain, making sure that they get their medications on time. If they're getting the aspirin and the NSAIDs, making sure that they get those medications, educating the parents, those types of supportive care. They're going to be very tired, so they're probably going to sleep a lot, but then we also encourage them to do activity while they're there in the hospital so that they can stay engaged and involved. So pretty much for rheumatic fever, it's going to be self-limiting after we give them the medications, but what they can have is long-term cardiac problems if their heart has been affected by this disease, by rheumatic fever. So the next disease we're going to talk about is Kawasaki's disease. So Kawasaki's disease is pretty common for children under 5. You'll see them come in the hospital with some specific symptoms that we're going to talk about. We don't know what the cause is, but usually it occurs after some kind of an infection, viral or bacterial. It is self-limiting, which means that it will resolve itself in 4 to 8 weeks, but we need to make sure that we treat them even though it's self-limiting, because this is the leading cause of acquired heart disease in children. So your symptoms are going to be about 6 basic symptoms. They're going to have red, bloodshot eyes. Their conjunctiva in their eyes are going to be swollen. They're going to be red. They're going to have this like very distinct strawberry, what they call a strawberry tongue. So, and they'll have red cracked lips, maybe even bleeding lips, but they'll get this strawberry type tongue looking. They can have swollen feet and rashes on their hands and feet. High fevers, so they have several days of high fevers. The rash can also be over their entire body, but these 6 symptoms are basically what we're going to use to diagnose Kawasaki's disease. There is no definitive blood test that we use for Kawasaki's. It's a kind of a rule-out diagnosis or a clinical symptom diagnosis. So we're looking at these clinical symptoms and we're saying, okay, they're diagnosed Kawasaki's. So the complications, and this is why it's the acquired cardiac defect, is that the inflammation can cause inflammation of the coronary arteries, which can result in an aneurysm. So we really need to make sure that we do a really good exam of their cardiac function. They will get an echocardiogram. They will be on EKG. They also can develop valvular problems, so their valves can become leaky or ineffective. Again, we talk about they're diagnosed by their symptoms, which include lymphadenopathy. So their lymph nodes are going to be really swollen, the red eyes, the cracked lips, the swollen hands, the high fevers. Generally, they're being brought in because of the high fevers and probably maybe a rash on their body. And then we have to rule out other causes. So basically, they'll do blood tests to rule out other causes so that they can be definitive in their diagnosis of Kawasaki's disease. So the treatment for Kawasaki's disease is they're going to get IVIG, and IVIG is a blood product. It is considered a blood product. So it is pooled product from donation, and it is given over a long period of time in the hospital. When you're giving IVIG, it is given only through IV. There's no oral form of this medication, but you're going to be giving it in what they call ramp up. So you're going to give it to them slowly at first and then increase the rate every half hour until you get to a maximum rate. And this is all going to be based on their weight. So it will be dosed on their weight, and we are going to set the pumps based on their weight and their dose. And this is probably something that if you had a patient like this that you would not be involved with, but it would be very interesting if you could see how this works. If a patient did get IVIG for Kawasaki's disease or any other inflammatory disease, because like we talked with MIS-C, is treated similar to Kawasaki, so they'll also be getting IVIG. We tell the parents, we educate the parents that they are to wait 11 months for any live vaccines. So it's definitely something that we need to make sure that we educate the parents on. The other treatment is high-dose aspirin. So we are going to give them high-dose aspirin, and they basically under the supervision of their primary care provider. They usually will start the high-dose aspirin while they're in the hospital and continue it when they're at home, but with specific doses. It's a short-term dose of high-dose aspirin. The reason why we have to watch them very closely is because aspirin has been associated with something called Reye's syndrome, and we will learn a little bit more about that later on in the course. But Reye's syndrome is kind of an encephalopathy syndrome. We're not exactly sure why it happens, but for children taking aspirin, there's a risk of developing this. And only children. Adults don't have this risk. It's the children that have this risk of Reye's syndrome. So we have to watch them very, very carefully. So here's just your references if you'd like to see that. For Kawasaki's disease, again, it does self-resolve. It will resolve with the help of the IVIG and the aspirin, and they will have follow-up care at the cardiologist. They will do an echocardiogram in the hospital to look at their structures, but we often send them to the cardiologist after they get discharged about 6 months later to make sure that there were no long-term effects, or if there were some effects on the heart, that they follow up to make sure that there's no continuing effects of cardiac. So that's it. Thanks, and I'll see you next week.